This okay? I'm very sorry I'm not there. And I have been to the Great Wall meeting before in Beijing, and sorry I couldn't be there in person. I'm going to talk a little bit about digital technology and build on the talks from Li Jing and also Prabhakan around secondary prevention. I work at the University of Sydney at the moment, and I'm happy to take emails if anyone wants to reach out, leading a big program. So this is a bit blurry, but this is where I live, about 1 hour north of Sydney, in a place called Terrigal, and I would be very happy for anyone to come and visit at any time if they like. I live just near the beach, and it's early afternoon here in Australia. So I just wanted to start off by sort of flagging the World Heart Federation roadmap for digital health in cardiology. This was back at the ESC in 2022 in Barcelona when we released the document. And I would encourage you all to have a look at this roadmap as well as others released by the World Heart Federation, because they give some framework and structure and ideas about how to, work through solutions in terms of implementing better care. And the digital health roadmap was the most recent one. There is currently another roadmap in secondary prevention under draft, soon to be released. So I just encourage you all to have a little look at that roadmap. And as was already said, we'll be holding the Emerging Leader Program for the World Heart Federation in Sydney in about 6 weeks' time, and it will be on digital health and based around this roadmap. So I wanted to touch on a couple of things. So it's quite timely to speak after the previous two speakers. I've been working in the area of cardiac rehabilitation and closing gaps and thinking about the problems in this space. And one of the things that we've been working on in a very large program funded here through Australian research funding, but also linking with our international colleagues, is thinking about cardiac rehabilitation and where do the problems come from? And it relates a little bit to that first slide that Prabhakan already showed in his presentation. So I'm going to just walk you through a bit of a timeline of where cardiac rehabilitation came from and how we can learn from this in terms of moving forward. It's published in the Frontiers of Cardiovascular Medicine, the reference there, if you'd like to look up the paper itself. But I'm just going to walk you through this visual. So if you may or may not have known, in Western countries anyway, prior to the 1950s, after a heart attack, people were put on bed rest, sometimes for up to 1 year. So they obviously became very deconditioned and then could hardly walk and look after themselves at that point. So they needed rehabilitation. And there was great fear that if people were active, that they would stress their heart and potentially have another heart attack. So in the 1960s, which I think Prabhakan was alluding to in somewhat with his kind of early image, which was nice, was that in about the 60s, we saw this pioneering work showing that heart attack survivors could actually sit in a chair and do light activities. So walk to the bathroom or around their room, and that this was safe. And indeed later work that this was actually beneficial to the heart to circulate and to actually, be used and to use other muscles in the body to, exercise. So what we saw in the 1970s, in Western countries at least, was a very large emergence of outpatient cardiac rehabilitation programs. So at the same time, though, we know coronary artery bypass graft surgery was also, coming of age. And we saw, but there was quite extensive stays in intensive care units, plus a lot of weeks in hospital. So we started to see people coming to these outpatient programs where they would do exercise in a safe environment to increase, to prevent this deconditioning and to overcome some of these things that had occurred in their bodies as a result of the treatment they had received. So we're talking about 50 years ago, so 1970, so about 50 years ago. I think the context is important. So then around the Western world, we saw proliferation of these cardiac rehabilitation programs and expansion to include some education about our other risk factors, as we learnt more from Framingham's study and others about risk factors, as Prabhakar and Li Jing have also alluded to. So we saw this group-based proliferation and organizations, come of age around the world. But I guess that's where things kind of start to shift. So then in the 1990s, we saw bypass surgery become more advanced, and we saw the introduction of non-surgical, percutaneous coronary intervention, stenting and angioplasty, and obviously shorter stays in hospital and day stays, and obviously in China, as is around the world, many, many people having these very small procedures done every day. But what has happened is our cardiac rehabilitation model still stays largely the same as it was back in the 1970s. So we're still tending to follow that same model from 50 years ago. So we know around the world from research, from many groups, that the programs tend to be largely unchanged, despite these enormous changes in surgical and medical care. And much shorter stays in hospital, and no sort of deconditioning anymore. Back was the case in the early 50s and 60s. And then, of course, we know society has, of course, changed a lot around the world, and culture and language and technology. And then, of course, we've had the COVID pandemic, which has shifted models of care. So I really just wanted to show you that timeline to help you think about cardiac rehabilitation and where it's come from and why it exists in the way that it does, and how we still, do things the same way mostly that we did 50 years ago, despite total changes in the way we care for patients. And so from my perspective, my mission is to try and improve this and help cardiac rehabilitation models and the way we care for people in secondary prevention catch up to some of those other areas. So I'm just going to kind of work through a few other pieces of work that I've done, and some of my colleagues are kind of along that journey. So this is one study. There are others. This is quite old now. I think it was in 2007, published in the Medical Journal of Australia, where what we found was those people that go to cardiac rehabilitation tend to be those people not accessing cardiac rehabilitation tend to be those with the highest risk factors and the lowest knowledge about risk factors. So in other words, in general, from a public health and population perspective, those going to cardiac rehabilitation are the ones that sort of need it the least. So there's this huge group of people that we need to help in some way that we're not getting to. So I said that. So we've also done some other work down here throughout the whole of Australia and New Zealand, and this mirrors other work. It's published in Heart back in 2014 now. But what we wanted to look at was, before someone leaves hospital after an acute coronary event, do they get basic information and basic advice and recommendations regarding lifestyle, medications, and rehabilitation? And then we looked at the combination of all of those. So pretty simple, but we wanted to look at it at scale. And so we did this, and we did modeling, and it's published in this paper. But I like to summarize things very easy. So basically, to cut a long story short, we found, certainly in Australia and New Zealand, and this mirrors other countries around the world, when you look at big data, you'll see only about 2/3 of people are discharged on the medications that are recommended in guidelines. Less than half, and I think that number is generous, and in other countries it would be much lower than that, including China and India and other, where less than half are referred to a rehab program. We know that less than half get advice about stopping smoking. We have recommendations in Australia and New Zealand to be screened for depression. That's the success rate of that is still very low. And then we know, not everyone gets the advice on diet and physical activity and things they should. And here in Australia, our Indigenous people, it is recommended that they say a specialist Indigenous health worker. And about half of those people receive that. But certainly in the country where I live, in New Zealand combined, we see that only about 1/4 of people who come to hospital with an acute event actually receive these things. Now, I would argue, and maybe in the conversation after, if there's time, I would imagine this is much higher or even lower percentage in a country like China with the vast population, and having very intensive programs is very difficult to get large populations to be able to access for a whole range of reasons that Prabhakar and Li Jing have also highlighted, and I won't go into today. So what we're saying is, this isn't really good enough. We need to help our patients, even when they've had a heart event, to have at least basic information, medications, and referrals. So with that background, there's a lot of things that we can think about and a lot of problems that we can identify, which is the subject of other whole talks, of course. But what I wanted to just move to here, building on those of the previous speakers, was to think about, obviously, digital health and technology. So technology, as we know, is now obviously widely available. And this didn't exist so much 15 years ago, before the first iPhone and other devices. And so how can we harness this to access something for more patients? And I think even in a country like China or my own or Tom's country in the US or Prabhakar in India, the theme is very consistent. How do we get something to a lot of people? And people are walking around with these devices on and in their pockets every day now. So how can we harness this technology is another area of my work. So I was just going to present to you a few things about a few programs we're doing. I wasn't going to go into the technicalities, but show you a few examples of some of the things that we're doing. And really, firstly, just to highlight the big grant that we have here in Australia, we now have around $16 million to do some work in this space, where we actually come together and be united to try to solve some of these challenges. And it is about technology, but it is about data as well. And again, it's another whole conversation. But if anyone is interested in learning more, I'm happy for you to reach out to me, and I will be hopefully at Shanghai over next year, as will some of the others speaking today at the WCC conference next year, which I'm very excited about. And I should say I had a fantastic trip to China booked for 2020, June, I think, and I was very excited about it. But of course, the whole thing never happened. So I'm very keen to come back to China. So our vision of this Solve CHD program, and you'll see we have a website if you wanted to look it up, but we want to optimize that out-of-hospital care and reduce the burden. And as I said, using data technology partnerships and capacity building. So I'm not going to go through these in detail, but basically here in Australia, we want to have a whole connected system for collecting data in cardiac rehabilitation. And we are working together with the International Cardiac Rehabilitation and Prevention Society, of which my colleagues are leading and we're involved with. And there is whole systems for how do we collect data. Cardiac rehabilitation tends often in many countries not to be part of the hospital system, but not to be part of the primary care system, and it gets a bit left in the middle. So we're also supporting innovative research projects, which I won't show all of them, but I can show a few. And then we're trying to build a whole capacity of new multidisciplinary researchers and clinicians and consumers working to be future leaders in this space. And it does tie in to the World Heart Federation Emerging Leader Program happening in Sydney in a few weeks' time. But again, happy for anyone to reach out. We have a network that people can join as well. So in terms of a couple of studies that we're working on within this whole program, I just wanted to show you two examples. One was Torpedo. The Torpedo study is actually completed. It was led by my colleague, David Pyrrhus, who works at the George Institute with me. He's a GP, and we led a big cluster trial. And we looked at 60 primary care practices. We were able to get data for around 38,500 patients. And we provided an electronic decision support system for doctors to help them implement evidence-based care. And you can find the results there in circulation, quality and safety. But basically, we found that the intervention was effective in improving the implementation of evidence-based information for patients. And we've built on that to be this, I think it ties into a few things Li Jing was talking about and Vakan. We've then done a big, well, we haven't done, we're almost finished, a big cluster randomized control trial here in Australia. It's what you would call a virtual clinical trial again. So the reason that I'm showing you that is we don't actually see any patients. It's all done remotely using data and electronically. Again, by doing clusters, we got 52 practices in this study and about 14,500 patients. And we look at using data to improve the quality of the care being delivered again at the patient level in the GP practice. We just are finalizing the 24-month data for that study, but it's a sort of study design thing, big trial. If you're interested, the protocol is published there in BMC Family Practice. But this is a little bit more about the study design of our Quell project, and I can talk a bit more potentially about this next year. But basically, we want to see whether that improves hospitalization. So by doing these virtual trials, we can get a lot more data from a lot more patients much more efficiently. It's funded by our National Health and Medical Research Council here in Australia. And we've got data at 12 and 24 months. And we're also doing almost all of my studies have a large implementation aspect, as Li Jing sort of spoke to, around can it be implemented? What are the barriers and enablers? What are the costs and all of that as well? So we haven't finished the analysis, but I wanted to share with you this study, and hopefully maybe next year I'll be able to present the results at one of the conferences. So, that got me thinking about cardiac rehabilitation a bit more as part of our SOLVE program. Now, I'm not sure. I haven't grown up in China. Many of my team are Chinese, which is fantastic, and I absolutely love them. But here in Australia, when I was a child, when I would go to the GP would fill in a bit of a card like this, writing what I had, what my blood pressure was, or what was wrong with me, and then they would put it in their filing cabinet that would look something like this. Now, obviously, this doesn't happen in primary care in Australia anyway, and around the world in most countries, not all, but because it's all electronic now. So what we want to do, but in cardiac rehabilitation, as I said, it kind of falls between the hospital and the primary care, certainly here where I live. And so the cardiac rehabilitation programs are still doing this, mostly, unfortunately. Maybe they save the PDF and upload it into the record, but not in an itemized way that we can then use the data. So this is our mission for cardiac rehabilitation. And so, this is just an example, obviously, at the GP. As you see the GP, they're typing in the blood pressure or whatever now, or putting it in an iPad or something like that, almost all of the time, not 100% of the time. So we want to move cardiac rehabilitation to this model as well. So this is a bit of an example, a bit of a visual of how the quality improvement works. You can look this up in the publication, but essentially you want to sort of use data to achieve a goal and implement strategies at the practice level to help people do that. We call those PDSA cycles. I'm sure Li Jing would be familiar with these, but basically where you sort of plan what you might do, you implement things, you see if it improves things, and then you go around the cycle again. So you might have a goal of using data to improve assessments and management. You go through a series of these cycles and hopefully use your data to monitor that change and benchmark to what others are doing, and hopefully increase the percentage of patients achieving a certain outcome. So changing tack from there, building on that, we have a big scheme here in Australia called the Medical Research Future Fund, a big federal government-funded research scheme for projects. And my wonderful colleague, Robin Gallagher, who is a professor of nursing, who you may have heard of, we've kind of built on that, and we've now got the cluster randomized control trial to do this in cardiac rehabilitation funded by this Medical Research Future Fund. We're only in the preliminary stages, but I just wanted to share this with you. So it mimics the other study. We'll have about 20 cardiac rehab programs, and we'll be using data again, and that model of plan, do, study, act, to use data to improve outcomes at the end, and hopefully see more patients participate in rehab and better outcomes and better quality of the service by using data. And of course, we know using data, you can't hide some of the patients. You don't get as many biases as when you have to recruit everyone. So there'll be more to come on that. That's our quicker study. Jumping around a little bit, another digital health study. So that was some data studies, but I've done a lot of other digital health studies. Another strategy, which I'm sure you probably may have heard of, is our texting work, led by myself and Professor Clara Chow, a cardiologist from here in Sydney that works with me. We first did our Text Me study, and we recruited 750 patients and did some one-way text messaging to support people in their behaviour change. That you can see some references at the bottom. We've published how we develop the content. We've published the results in JAMA. We've published the process evaluation and unpacking how this intervention was so successful, and also cost effectiveness. So we did find significant improvements across the risk factors. We found the patients very much liked the program, which was very interesting, quite simple. I think to Li Jing made the point, keep it simple, stupid. And this is a very kind of simple strategy that is complex in the background, but looks simple at the front, and the patients absolutely loved it. We also found it was cost effective. So I said, you can look up those papers, or I'm happy to share anything with anyone if you're interested. So this is just a screenshot of the primary paper published in JAMA. If you haven't already heard of it, it's a highly cited paper and a bit of a landmark paper in text messaging, where we found a reduction in multiple risk factors. And this is a bit of a summary of the sort of the work we've published in PLOS about what the patients said. So I think the first time when I heard what the patients had to say, I was like, wow, they really liked it, and it really surprised me how much they liked it. They felt this had a very positive impact. They felt they were really needed, and it helped them change what they were doing, and it gave them a good feeling to think somebody cared about them. So another type of study that we've done is a kind of app version thing that we've done called Connect, and we developed a whole system and got this also funded by our national government. And I won't go into too much detail, but this is what the kind of home screen looks like. You might see that there are what we call our learn things, so where people can learn about their condition. The interesting thing about this particular system is it's fully integrated with the GP's data. So we can sync all of the data into this app directly from the primary care provider and vice versa. So this was very different to just an app where you type things in. And then we have some acting things where people can set goals and get rewards and check their progress. And standard things where they can share and interact with others. And then you'll see some healthy tips, which is a little bit similar to our texting work, and obviously standard settings and things like that in any app. So we've published this work in the Nature Partner Journal Digital Medicine back in 2020. It was a randomized control trial, and let's see how many we had, 18-month follow-up. We had just under 1,000 patients in primary care. And we found improved things like health literacy, some improvement in some risk factors, but it didn't improve everything. So these digital health things are not a quick and easy solution for everybody in every circumstance. Another project that we did, led by my fantastic PhD student, Carla Santo, who is from Brazil, Brazilian cardiologist, has been a World Heart Federation emerging leader. She lives in Brazil again now. But we did a randomized control trial looking at a couple of apps that existed to see if they would improve medication adherence. So she investigated a simple app, a more interactive complex app, and a control condition. And this is the primary paper resulting from her work. And she found that those that used an app did better than those that didn't use an app. She only followed up for 3 months for this particular study. But a very fancy app with a lot of complex features wasn't any better than a simple app. And again, speaks to Li Jing's previous comment, which resonates with me as well. I've got a couple of more examples for you. Another one is our study we called My Heartmate. This was very much a pilot kind of idea, led by, again, Robin Gallagher and my other fantastic colleague, Gemma Figtree, who's a cardiologist here in Sydney. And together we developed kind of like more a game. So we wanted to test gamification. And I think that's a real untapped area for patients. Why do we go in and play games on our phone? when we might not manage our heart disease. So how do we get into the psychology of that? And this was having a initial think about that, and maybe that's something people in the audience could think about. But anyway, we wanted to look at changing risk factors, and we followed people up for 6 months. But we found no significant increase in the physical activity, but the patients liked it. So maybe there's something there. It needed a lot more work. It was very much a prototype, and I'm sure the amazing colleagues in the audience could do something much more fancy. It was very preliminary and sort of budget friendly. So I think this is kind of coming to the end of my talk, but I guess I just wanted to, I'm not sure whether you can access our website over there where you all are, but this is our website. People can sign in and join our network if you want to hear more about some of the things we're doing. We have got a lot of opportunities to work together. Or, you can just email me. My email, you can Google me and you'll find me, or my email was on that first slide and I think is on the last slide if you can't access this website. I'm not too sure. And I did just want to finish showing, this is in Australia anyway, this is a bit of a bubble diagram thing that we've also published in Nature Partner Journal. It's got international colleagues, but this is the Australian version. All the people around the world working in digital health and secondary prevention is published in this Nature paper. And these are some of the amazing colleagues that I've worked with over the years. So there you have the end of my talk, Tom, and my email on the screen. But anyone Google me, and I think I'm the only one that comes up. Happy to have anyone reach out to me at any time and see how we can collaborate. So hopefully I'll be in Shanghai next year. Over to you, Tom.